We're going to go with the... Oh, hey there, this is Dr. Evan Osar. Welcome to this edition of Integrative Movement Insider. Happy Tuesday. It's a beautiful day here in the Midwest. Hope it's lovely where you are as well. It's National Women's Health Week. So in this edition of Integrative Movement Insider, I want to share with you a strategy for women that have unstable knees or ligament laxity in their knees. Discuss a couple different reasons why some of your female clients have ligament laxity in their knees. And then also what you can do from a exercise and corrective exercise and functional training standpoint. This is going to lead into our discussion this weekend on Two Anatomy Geeks, where we're discussing all things women. I should say all things. The anatomy. Last week we covered the pelvic floor and some of the anatomy around the pelvic floor, and then how to activate the pelvic floor. Today, I should say this Saturday, we're going to continue that conversation and then also add to the conversation. Because one of the things that we're going to see, well, you'll see with your clients, one of the things we see in our clinic here with our female clients is during the menstrual cycle, and again, it may be a little bit before the menstrual cycle, maybe just a little bit after, a lot of women will come in with chronic, or I should say not chronic, but tightness around that, or discomfort, or their core just isn't working as well or connecting as well as they normally can with it. They may even have a bit of ligament laxity during that time because again, remember that the whole purpose of the menstrual cycle is to sort of prepare these women for having a baby. So one of the things that my wife, Janice Manick, who specializes in working with women, especially women post-surgical, one of the things that a lot of women come to her with is pain or discomfort around their menstrual cycle. And she'll do visceral work and the things that she knows how to do and specializes in and exercises around that. One of the things she has women do is track their cycle. So that way you can start to get a sense of the woman's cycle and then your client's cycle, and then also how to program around that. Because if a woman is experiencing more tightness or discomfort, their core is disconnected because they may have some swelling, bloating, discomfort in their abdomen or pelvic region, and or they're having a bit of ligament laxity, maybe you need to change or modify your exercise programming during that time. And you may ask, like, Dr. Osar, where's the research around that? Well, we actually looked at the research. Janice and I spent almost an entire day looking at the research around the menstrual cycle. Is there any correlation between the menstrual cycle and women, especially female athletes? And there isn't much. However, there is some indication that, yes, hormones do relate to the increased incidence of ACL injuries, because I believe it's like 2 to 3 times, actually some resources say up to 6 times higher in females than it is in males around the same ages. So we know that women have a huge issue around ACLs. And again, we might as well discuss all the ligaments, right? It's just not the knees, just easy to track knee injuries. And even though the research is inconclusive, there's actually a research study I found from 2021 that they're actually looking at all the research right now. So they're doing a meta-analysis and cumulative study of all the research out there, and because now there's enough information where they can actually look at because enough women have tracked their cycles and they've tracked the injury rates and what point of the cycle did these women get their ACL injuries. So they're conducting all that information right now, that research right now, so that information won't be out for a couple of years. But where does that leave you and I? So number one, have your women track their cycle, especially if you start to notice a sort of correlation between how they feel around their menstrual cycle. Have them track their menstrual cycle. So that way you can sort of get a sense of when you may need to modify their training. Next piece is understanding what causes knee laxity. There's many different reasons. For example, I have several clients that I've worked with, and I have one client in particular that I'm working with that has the or Ehlers-Danlos syndrome, which is a connective tissue. It's a genetic condition where you have a ligament. These individuals have a ligament laxity. They thought I had Marfan's syndrome as a kid, and I probably have some level of it because my ligaments, my joint capsules tend to be on the more mobile side. So some people are just genetically engineered or born with just looser ligaments because of maybe a condition like this, or they're just more lax individuals. So it could just be they have more lax ligaments. So again, with those individuals, you just have to modify their training, their range of motion, and not allow them to sit into their hypermobility. For example, some of these women that are very hypermobile, they'll just kind of lock their knees out and just kind of hang out there in that position. probably want to just get them out of that hyperextension, or even the valgus, they may be hypermobile into valgus position. So just kind of keep them out of locked into those positions so they don't keep feeding into that hypermobility. Now, another reason they could have hypermobile or mobility around their knee, especially we'll talk more about the valgus knee position, is they could have had a previous injury. So if they sprained an ankle and or knee, in sports, or just stepping off a sidewalk or something, they could have true ligamentous laxity because of that. Maybe the ligament did heal, but now it's a little bit more overstretched on one side of the joint and shortened on the other side of the joint. So as we're talking about ligament laxity around the knee, we'll talk valgus knee just because it's very common and very easy to sort of visualize this. You can have overstretching of the medial collateral ligament, so the ligament that holds the inside of the knee stable, and you have shortening of the lateral collateral ligament. You may have overstretching of the ACL without tearing. You may just have overstretching, or maybe it was torn and it healed. So you can have overstretching of the ACL ligament as well. That creates a propensity towards that valgus knee position. Now, the third reason is you can have degenerative changes of the knee. So if a woman had an injury, or their bone structure, I should say their anatomy is set up where they have a wider pelvis and just a more genuinely, anatomically, anatomically more valgus knee position, and they haven't done training or the appropriate training to align and control their joints, well, then again, they can have the same issue with ligament laxity on the inside of their knee, more compression on the outside of their knee, and then over years, now they're starting to degenerate the cartilage on the outside of their knee as they start to drive their knee into more of that valgus position. Okay, now knowing that, what do we do about it? Regardless of the reason why, whether it's a genetic issue, whether it's a post-injury issue or post-surgical issue, or it's a degenerative change, we want to help our clients align and control the femur and tibia. I'm going to come up here a bit closer so you get a better view of this. Hopefully I'm still on screen here. But we want the femoral condyles, so the femoral condyles, to sit on top of the tibial plateau or the tibial condyles. Remember, the meniscus is in here. Obviously, you have your ACL and PCL in here controlling rotation, controlling anterior and posterior displacement of the tibia. But you want to control the femur on top of the tibia so that when these women are squatting, lunging, walking, stepping, that they have alignment of the femur over the tibia. When we squat, for example, it doesn't mean that this is just a pure hinge joint, because it's not. We actually have rotation around the knee. Oftentimes when there's stiffness of the ankle or foot complex and or stiffness of the hip, the knee is a very easy way to compensate around that loss of range of motion, okay, or that loss of mobility. So oftentimes the individual, when they go into their squat position, rather than being able to, what they should be able to do is externally rotate their femur, relatively speaking, on the tibia, which is actually was what unlocks the knee so they can actually bend the knee. Well, they also need to keep the tibia relatively well controlled underneath that so the weight stays across the foot tripod, the big toe, small toe, and heel. Well, if the individual doesn't control that position, they can increase that lateral compression. The tibia will externally rotate, femur will adduct and or internally rotate, and now you get more lateral compression, you get more of that stretching on the inside of the knee. Now, if that's your client, just putting a band around their knees and pushing the knees out, not going to solve that issue. I should say temporarily it's going to solve that issue. It's not addressing the underlying issue as to what's causing it, the ankle or foot and or hip. So that's why one of the easy assessments you can do to see if it's your client's hip, is have them stand with their feet underneath their pelvis, have them rotate one direction, have them come back, rotate the other direction. There should be very easy motion of the pelvis rotating around that femoral head. That's the internal rotation we need. That generally will give you the sense that your client has good ability to hip hinge and rotate their hip in the acetabulum. Okay? Another assessment you can do is just have your client in bare feet and then look at the feet as a squat. What does the foot do? If your client's on the outside of their foot, one of the ways your client will get the weight over the inside of their foot is they will start to drive that knee in. So it's not always because they have a weakness of their hip abductors and tightness of their adductors. In fact, that's rarely the case. It's because there's something through the hip, the ankle and foot, and or up here at the trunk, because up here at the trunk also drives what happens down at the knee and lower extremity. So it's one of those reasons that's driving that knee valgus, and just working on moving the knees out isn't solving. It's a temporary solve, but it may actually be putting the client more, if their foot is the reason, is putting their weight more on the outside of their foot. So the first thing we got to do is figure out why. So now let's just say it's lateral compression. They have shortness of the muscles on the outside of their leg that's driving the leg in like that. So first we got to do some myofascial release to release the lateral muscles like the biceps femoris. The biceps femoris, again, is attaching to the fibular head. When it's short and tight, which it often is in a lot of your clients with chronic valgus knee position and chronic knee issues, is it will externally rotate the tibia. It will laterally compress the knee. It will overstretch those medial knee ligaments. So we have to release and lengthen that biceps femoris. So you'll do your myofascial release on the hip. You'll do your lengthening on the biceps femoris. You may even have to release the lateral gastroc, because that also crosses the knee. The lateral gastroc and the biceps femoris almost cross each other to provide lateral knee stability. So that provides a lot of our stability when we get onto single leg stance. So you may need to release that as well. Well, next you have to teach your client how to control that position, because if you just release it, it's still a good step in the right direction. It's usually not enough. One of the best ways to teach your client how to control, slide Bucky off to the side here, is by teaching your client first how to align their thoracolpelvic cylinder. So that's a first step. Get their thoracolpelvic cylinder aligned. Get their foot tripod aligned. Should take my shoes off. Actually, I'll kick them off right now. So get their foot tripod aligned, big toe, small toe, and heel. Then make sure the pelvis from there is squared up to that foot tripod. Okay, so that way, at least if your client is in valgus, you put the foot tripod down and then you bring the cylinder around and the pelvis around. Well, now this pelvis is aligned to the foot, and that will oftentimes bring your client back out of that valgus and that rotated tibia position. So now the femur and tibia are better aligned, and now you can just teach your client, if they have knee problems, you may just do a hip hinge. So from here, just teaching them how to hinge and maintain that alignment. If you can squat, then you do a split squat. Get them squatting to load that foot tripod to align and control the hip, knee, ankle, and foot. So just two different ways to teach your client how to align and control that knee position. A progression from that is now you want to teach your client how to be here in this position. So from the split squat, you can also always have your client step out, step back, step at a diagonal. So that way they're learning how to move the opposite limb and control the hip, knee, ankle, and foot position. So again, we don't just put a band around the knees until we teach our clients, and we are confident that they're able to control the hip, knee, ankle, and foot tripod. Because just putting a band, like I said, it won't change the alignment and control of the foot and or hip if that's what's driving the knee issue. All it does is work the hip abductors, which your clients may need, but it's not addressing the underlying issue that led to that valgus knee position in the first place. Then, of course, you want to load your client. You want to teach them how to squat and or do some kind of loaded deadlift position, hip hinge position if they have knee problems. Hinging is the go-to. Bridging is are the go-to patterns to help your client own and maintain these positions without overloading the knee. And for a lot of our clients, our older clients, female clients that are coming in with valgus knees and knee degeneration, they're either trying to prolong before they need a knee surgery, or they are coming back from knee surgery or some kind of surgery. This is the same strategy we'll use with them to get them going once they've had surgery. So you want to help your client create a strategy that helps them prepare for surgery and or prolong surgery. And some of our clients we've had a lot of clients that have done PRP, so plasma-rich protein, and or stem cells. And actually what the success that they've had is actually the injections actually help bring nutrients to the joint, maybe rebuild cartilage, strengthen the ligaments, but it doesn't change the mechanics. Most of these women that have had these procedures, PRP and or stem cell, they only really take the next step when they change the mechanics, the alignment and control, so that they're not overloading the tissue, especially that new tissue that they've just created. So you can work a lot with those clients that have had those procedures as well. So I hope that makes sense. I hope it gives you some ideas. And it doesn't matter if your client has ligament laxity because of genetic issue, whether it's because of injury and or degenerative changes. It's really the same concepts with each client. Just understanding the limitations. Again, if you have a client that has Ehlers-Danlos or some kind of, they're born with some kind of ligament laxity, there's only so much you're going to be able to do. Focus more on stability, that really creating strength and stability, keeping them out of end range. If you have a client that has degenerative changes, then really work on aligning and controlling and being very specific with the exercise patterns you use, so you're not overloading the degenerated tissue, and you're giving them a strategy for aligning and controlling. If you have a client that's coming out of surgery, then help them create a more optimal strategy after surgery. And that's how you become the go-to specialist for your current clients and attract more individuals, more women that need, want, and will pay you for your expertise. And if you're looking for an additional resource on Two Anatomy Geeks this week, last week we talked about the pelvic floor. This week we're going to continue our discussion on the pelvic floor, strategies to help improve pelvic floor function, which is basically the core. It's the stability of your core. And then I had one woman post on Instagram. So if you don't follow us on Instagram, it's at IIHFE. She's like, men have pelvic floors too. I'm like, got it. Yes, I know. Yes, I'm very familiar with the pelvic floor. I shouldn't say very familiar. I'm familiar that men have pelvic floors as well. And a lot of the same strategies, apply to men as well. So yes, thank you for that comment. So last week we talked pelvic floor. This week we're continuing the discussion on the pelvic floor because so many women have stress urinary incontinence and or hip issues related to the pelvic floor. So we're addressing that. This week specifically, we're addressing the menstrual cycle and how to work with women post-surgery. So women that have had C-sections, hysterectomies, GI surgeries, gallbladder surgeries, because we see lots of women, like I said, my wife Janice is a specialist in working with women after surgery. So we see a lot of changes in core function, pelvic floor function, breathing, core stabilization, stabilizing their spine after surgery. So we'll be sharing some of the strategies we use here in our office. She'll be our guest geek this week. And then next week in part 3 of the series, we're coming back to discuss bone density. And I also did a couple interviews with my personal nutritionist. So she talks about a nutritional approach to bone density because obviously your women need that as well. We'll talk more from a resistance training standpoint. I have interviews with 2 women, 2 of our integrative movement specialists, one that works here in our office, Sarah, as well as another one of our integrative movement specialists, Jana, who both had C-sections, and they talk about their experience after a C-section, how it changed their body, what they currently do from a training standpoint, how they work with their female clients. And then I have an interview with a pelvic floor therapist that we also work with, a colleague of mine that I did an interview with, and she shares some of her strategies that she works specifically with women. So we put a lot of information into this resource for you so that you have good information because, again, I don't specialize in working with women, but I'd say probably 70% of my practice is women. And I attribute that to, I must be very sensitive. I grew up in a family with a dominant mother and six sisters. So there's a lot of estrogen running around my house back in those days, female dog, female cat. So yeah, so I'm very sensitive and I work with only women here. Not that I wouldn't work with a man. We just only have women on our staff right now. So it's a topic that we're going to see. People we're going to see. This is the population that has been attracted to me, and somehow the universe has sent these women to me to help. And you likely have the same sort of population that you work with, unless you specialize in men. But again, a lot of the same information applies to men as well. So this is Dr. Evan Osar. Thanks so much for watching. Thanks for being part of our community. I'm going to put the link next to this video and join us for Two Anatomy Geeks. It's a great community. And till next week, go out there, be the leader for your community, empower your women, educate and empower your women, help them be the best leaders they can be for their communities. And we look forward to serving you, helping you. And if there's anything we could do, just let us know. Take care. Have a great Tuesday.